in just one look, you have a big overview of what an organ looks like in terms of vasculature, in terms of vessels, artery, veins, until the smallest vessels.
What if you could see every blood vessel in a patient's heart, kidney, or liver down to vessels smaller than a human hair, all in real time? Welcome to the Convergence on ReachMD, where innovators and physicians explore the technology transforming medicine. I'm Dr. Brian McDonough, and today I'm speaking with Dr. Clément Papadacci, who has built an ultrasound probe that does exactly that. Dr. Papadacci is a researcher at Inserm and the Physics for Medicine Institute in Paris. Dr. Papadacci, thanks for being here.
Thanks for inviting me, Brian, and hello, everyone. And let's take a big dive on ultrasound domain.
Let's start with what you've achieved. You recently published in Nature Communications showing 4D blood flow mapping entire organs. Can you walk us through what that actually means for someone holding an ultrasound probe?
Yeah, of course. It's a very, very nice journey that I end up on this magnificent study. Like you said, we can see the vasculature of a whole organ in 4D. So first, let's define what 4D means. We used to say it's 3Ds plus time. So the fourth dimension here, it's time. So what does that mean? It means you can see the three spatial dimension, like you would see a baby in the belly of her mom, but you add also the time dimension, and you see the blood flowing in the veins, the blood flowing in the arteries at very, very slow motion. Because I would add to that the time dimension is sampled very finely, meaning that you have a lot of details in the time. You can see slow motion of the blood, which gives you access to many, many, many parameters.
So what does these images look like from your perspective, the colors, those sorts of things?
It's really fascinating to see them because you can see something like the true nature. You can see, for instance, the liver that looks like a tree with the big trunk and the branch that ramifies and becomes smaller and smaller. So you really have a sense of the beauty of nature. Like, I don't know if you're familiar with the term fractal, which means that you see division and division of branches. So it's exactly the same for blood vessels. And so what you can do, for instance, you can color the arteries in red, the veins in blue. You can set up the flow velocity. You make it clearer when it's fast and darker when it's slow. And you can see these maps in 3D of the veins and arteries. And if you play the movie, you see moving this blood inside the branches until the very smallest vessel, which can be like 100 microns, 50 microns. So very, very small vessels.
You mentioned the liver, and you've tested this in hearts, kidneys, and livers in animal models. What did you see that was impossible to see before?
What I could see is the different scales of the organ. So what does that mean? So, as a physician, I like talking about scale. So let's say the big scale is the whole organ. I can see the organ, the entire organ. And it's in animal models, like you said, and it's porcine models. The interest of using porcine models that they have organs of the size of humans. So if it works in porcs, it's going to work on humans. And so for the first time, we saw the whole organ and at the micron scale. So you see this difference of scale. So the whole organ is about 10 centimeters. And you can see details inside these organs that about 100 micrometers. So in just one look, you have a big overview of what an organ looks like in terms of vasculature, in terms of vessels, artery, veins, until the smallest vessels. And this was impossible before because of the ultrasound technology.
That's a good point. This is completely non-invasive no contrast agents, no radiation. And as a physician, I'm used to ordering CT angiograms, MR angiography, this sorts of thing. What is different about what your probe shows and the advantages of not having to deal with those things?
So we don't need an injection of microbubbles, which are used in the clinic already in some application of ecography, which is so there are microbubble of gas that are usually used to enhance the contrast of blood vessels. So it's used for cardiac applications, for instance. You're going to inject these microbubbles to see the cavity of the heart filled with the microbubbles. There are some application also on the carotid. You're going to inject the microbubbles to see well the blood in the carotid and do some quantification. It's also used in the brain to see better the circle of Willis. So it's microbubbles that are available in the clinics in the US, in the Europe. So there's no big issue about that. Clinicians, they are used to inject these microbubbles. And the specificity of our work is that we're going to inject a diluted solution of microbubbles, so less microbubbles, because what you want at the end is to follow and track individually these microbubbles. So this is the key invention in this work. It's called ULM, ultrasound localization microscopy. It's a technique that is been invented 10 years ago. It was pioneered in the lab. So I come from this culture of so it's called ULM. And so this ULM enables you to see this different scale of vasculature from the big vessel to the smallest vessels. But the field of view was really limited. It was limited. First, it was developed, of course, for 2D images. So the first application of this technique was performed on the brain, on the rat brain. It was just a slice of the rat brain, and you could see very well the vessels, the neocortex, the nucleus more deep in the brain. And then it has been extended to 3D. And people, they were very interested to see in 3D because, of course, all this vasculature, they are three-dimensional and they are very complex in the brain, in the heart, the coronaries. So it's a work also that I did with Mathieu Pernaut. It was to see the coronaries in a rat heart. So the coronaries, they are veins and artery that feeds the muscle, the heart muscle, because the heart needs nutrients like any other muscles. But there was a problem to extend the field of view and to apply it to a human organ. And this is really the key of this invention. And why you're inviting me today is because we invented this probe of the future that is able to see a whole organ of the size of a human and to see the microvasculature. And it comes really from this to scale up these probe technologies to a big probe that can see large organs.
You did your dual bachelor's degree in physics and cinema. When I was in school, it was English and biology. And I know in my life, the English major part has revealed itself through broadcasting journalism, writing, and those things. And clearly you have physics and cinema. How does that creative background influence how you approach medical imaging research? Because you obviously must have the ability to visualize things that most of us can't.
Yeah, it's a very good point. I was passionate with cinema from very young, and because I had some ability in mathematics and physics, my dad, that's very rooted. It's very feet on the ground. Told me, okay, why you okay, you can do cinema, but why won't you continue physics in the same time? So because I had I liked challenges, I kept the two. And what I was passionate about cinema is what you were telling, like visualization, the beauty of images, but also telling stories. And the third thing that I was very attracted with cinema is the creativity that you can get there. And then when I continued, I left and I studied in Oxford University physics. I could not continue at the time. It was just 1 year abroad, and I really discovered what physics could do. And when I continue in the internship, um, I really was very passionate about applications of physics, and especially in the medical field. And when I started to work on imaging, I could see that images and cinema, they were very close, because um, the way you're going to represent your data is not that obvious. You need to choose the color of the arteries. You need to choose the color of the paints. You need to choose the frame rate you're gonna show the results. So there is a big part of visualization. And now that my research refocus on 3D and 4D, it becomes even more true. To give you a story in the lab, so we have an engineer that specializes in visualization and helps us to do this beautiful movie for people to understand what we do, and is using a software that's took from the cinema. It's called Houdini software, and they use it for explosions. They use it for special effects, and but it's also very, very powerful for scientific data, especially 4D, because how do you represent 4D? There is our eye can see only in 2D, and to get the sensation of 3D, you need to move around, you know. And it's exactly the same when you represent 3D and 4D data. You need to move around. You need to cut inside. You need to choose the plane of view to represent what you want to show. So I think it's very, very similar approach as cinema. Of course, I don't tell story to fantasy story. I want to tell true story in science. But there's also this choice of what I'm going to show, how am I going to show, and of course here physicians they are very, very important for that. They help us, they guide us, they tell us what they want to see, and sometimes they don't know they want to see, and we need to give them tools and visualization for them to understand the images.
Things have come so far. Early in my career, obviously a lot older, we used that concept of 24 frames per second, and you could do stop action and educate people by having the stop action movement, which obviously is so old. But at the time, you were able to kind of educate, giving people those images. And it's so exciting that you can do that now for education and treatment. So let's bring it back to the real world. Let's say I'm an emergency room physician, patient comes with some sort of acute kidney injury. How would the technology that you have help in ways a current ultrasound can't?
Yeah, it's a very good question, and it's very linked to all the diseases that are linked to microcirculation. Microcirculation, when you talk to a physician and you are one, obviously, they are fascinated about it because they can't see it. And it's important in so many diseases, and they get the feeling that when the diagnosis is complicated, the microcirculation is involved. So actually, everything has to be discovered on this point, because you need to show them for the first time how microcirculation gets altered in some pathologies. So of course we have ideas. You mentioned the kidney. We're going to work on nephrologiosclerosis, which is a pathology of the kidney that affects arterioles and big vessels, but also glomeruli. Glomeruli is a big goal line in the imaging of the kidney. So if one day you offer a clinician a way to see them, to quantify them, and to tell, okay, it's abnormal because the density of glomeruli in this patient is too low compared to what I know from healthy volunteers, then you really would make a difference in the kidney world. So I'm hoping that this kind of technology, I will be able to build some device and put in hand of physicians that have ideas on their pathologies, and they think that microcirculation is involved, for them to characterize their pathology and to understand how microcirculation plays a role here. And I think it's key in many, many pathologies.
Most of us have learned, many of my colleagues and I have learned ultrasound on conventional machines. And now we're talking about a golden age of ultrasound, thanks to ultrafast imaging, which was pioneered 20 years ago at your institute. What is that, like conventional versus ultrafast? What is the difference?
So ultrasound it's a beautiful modality for sure because it's real time, it's portable, it's easy to use. Of course, you need to get some training, but when you have it in your unit, it becomes an essential tool for many organs. For instance, the heart, you can see it in real time moving and play with the parameters, and then you get the Doppler, and you get so you have many good parameters, good imaging techniques that are able to screen some patients. This being said, what have been done since it was invented, let's say, and clinically applied 40 years ago, the main goal of device constructor was to enhance the imaging quality. You see the resolution means the details that you're going to see. The contrast, it means how dark you want to see is dark and how bright what you want to see is bright. So these two parameters, they wanted to enhance it. And it was the only research that was done, basically. And what ultrafast imaging permitted, so just a brief explanation of what it is. Ultrafast imaging is looking inside the body at ultrafast frame rate. So what does that mean? A frame rate, it's the speed you see the image. For instance, your eye is seeing basically 50 images per second, 60 images per second. This is real time. This is what enables you to see reality and things moving around you. Ultrafast imaging can go 1,000 images per second, 10,000 images per second. So what you can see is completely different. For instance, I'm going to give you an example of what you can see in the human body. When you feel your wrist, you feel your pulse wave, and this pulse wave is basically a shear wave that propagates inside your arteries. And if you film it with ultrafast imaging, you see this shear wave in red and blue moving around your artery. Another example is the valve closure inside your heart. When the aortic valve or the mitral valve closes, they send a little earthquake inside the heart, and you can see the propagation of this shear wave all around your heart. And this is only possible with ultrafast imaging because these waves are too fast. We are talking about order of magnitude of meter per second. So to see them, you need really a very high frame rate. And then, like we said earlier, with slow motion, you can see very slow this wave propagating all around. And you're going to tell me, so what is it for? And why do you need that? It's because these shear waves, they have the magic property of being directly related to stiffness inside the body. So if you can measure the speed, you can measure their stiffness. And it's actually the first big application that occurred with this technology of ultrafast imaging. It was generating a shear wave and creating a map of stiffness where you generated the shear wave. It was applied, for instance, on breast cancer, where sometimes you want to know if the carcinoma is in remission. So instead of doing a biopsy, you can make a stiffness map and see if the stiffness decreases. It means that the carcinoma is in remission. So just to tell you, as a summary, this golden age come from this ultrafast imaging. I just quoted one application, but there are many.
I was thinking about here in the United States, probably not as big a problem in Paris, but we have a lot of people with metabolic syndrome and increased, because of diet and other things, fatty liver. And FibroScan is something many U.S. physicians order for liver fibrosis staging to see if fatty liver is getting worse. And that uses shear wave elastography from ultrafast ultrasound. So can you walk us through how that works and why it's replacing liver biopsies in many cases?
Yeah, of course, it's a very, very great example of how shear wave elastography made a difference in the clinics. With this a device that you mentioned, so this company was created from the work that I was doing 20 years ago in the lab by Michael Tanter and Laurent Sauvin. They created this technology. So what they do is that they make a hit, a little vibration on top of the body of a patient, and it creates this shear wave. And the propagation of this shear wave is really magic and fantastic because their velocity is directly linked to the stiffness. So then you get a detector that's going to measure the velocity of this shear wave at ultra fast frame rate, and then you're going to get the stiffness, and you are able to grade the fibrosis in this patient, and they showed that depending on the stiffness, the shear wave velocity that you measure, then you are grade 0, grade 1, or grade 2, grade 4. So it enables to really discriminate the patient and to know how bad is the disease, and then you get the therapeutic decision based on that.
Briefly, just wanted to ask you how ultrafast imaging impacted traditional Doppler studies as well.
Yeah. So very briefly, because ultrafast imaging is very fast, you get a lot of more temporal information. And because Doppler is studying the motion of the blood, more temporal information you have and more sensitive is your Doppler. So already some device manufacturer, they use ultrafast Doppler to increase the sensitivity of their images.
That's why I wanted to bring that up, because I want to move on to ultrasound localization microscopy to 4D imaging. Where that is, we have ultrasound localization microscopy is probably new to most physicians. What is it, and why is this such a big deal?
Yeah, so I'm going to go back a little bit in the physics there, just for you to understand what's limiting today the ultrasound to be able to make this microcirculation imaging. So basically, we talked a little bit about the resolution earlier. The resolution tells you what details you can see in your image, and the resolution is directly linked to the wavelength. The wavelength is linked to the frequency of your probe. So any sonographer that are listening to us, or physician that already used an ultrasound device, they're going to choose their probe, and they know this one has 5 megahertz frequency, this one has 2 megahertz frequency. For example, 3 megahertz frequency is for the heart. 5 megahertz is going to be more the liver or the kidney, and so on. And this frequency is directly linked to the detail that you can see. And this detail is about 1 millimeter, 5 millimeters, basically. And you cannot do anything about that. It's come from physics. It's a barrier that you cannot break. The ultrasound localization microscopy uses a trick. And the trick is, if you send and if you inject some microbubbles and you can localize them, then and track them, then you're not limited by the resolution of the wavelengths. You're limited only to the path that's gonna take the microbubble. If the microbubble take a path in a 4 micrometer vessel and you can track it, then you can resolve a 4 micrometer vessel. It's as simple as that. You have these microbubbles, and if you can track them individually, follow their path, and then if they take a path in the smallest vessel, then you are able to resolve it. And it's as simple as that, but it works. And of course, to construct a map of the vasculature from the biggest vessel to the smallest vessel, then you need to wait and accumulate the frames, because you have at each bifurcation, you have the probability that the microbubbles go, or whether right or left. So you need to cover all the possibilities to recover the entire map of the vasculature. And when you've done that, you accumulate everything and you get a full vessel mapping from the biggest vessel to the smallest.
And that obviously matters a great deal because you now get a greater sense of what's going on, right? I mean, you're seeing imaging that makes a real difference.
Yeah, exactly. So what's very strong about that is that we don't just localize these microbubbles, we're also following them. And with the tracking, like we call it, you get the velocity. And the velocity is so important because it gets you a sense of the function of the organ. It's not just a static images, like many modalities only gives you. It's also dynamic. So that's why we really want to emphasize on the 4D part of this technology. And then we can retrieve some very interesting index, the flow rate. That's so important because of course, you can calculate the radius, you have the velocity, you can get, so the flow rate, the resistivity also, that's very important. And so many other parameters that the clinician are interested in, tortuosity. Actually, we still have some hidden index, and we need to discover them. And I think it's going to make a great deal.
You know, it's interesting. I read one of the things you have where you said that structure tells you about disease, dynamics tells you about function. And the function is that the key of what we're doing, we're trying to treat patients, because that's really how it's revealed to them in one symptom or another. And this has to be so helpful.
Yeah, I agree completely. There are many ways to see the function of the organ, but in many diseases, it's indirect. You cannot really see deep in the organ how is the function. So, for instance, to evaluate the coronary function, you can inject vasodilatators to see the reserve of the coronaries, but you do it only for big vessels. Here you can imagine doing it also for the smallest vessels. You can do the same kind of stuff with the circle of Willis, for instance, to see the reserve of the circle of Willis. To see if these arteries still have reserve. You ask the patient to hold their breath to create a vasodilatation, and this you can see it and follow it with this technique.
I understand the concept, and I think a lot of our listeners and those viewing do, of going from 2D to 3D to 4D for entire organs. It's one thing understanding it. It's another thing looking at the conceptual and technological challenges that you faced. What were some of those things as you were moving? Because I'm sure that wasn't easy.
No, that was not easy. And we needed to go back to the physics, and I'm going to explain you why. So the current technology, they are based on piezoelectricity, where this is the way to emit ultrasound in the body. It's been discovered 100 years ago, and it's really the basis of ultrasound. And these probes that are able to do 3D, they are matrix. It means they are squared. Okay. And this square, it's a sample. It means that it's cut in many, many, many pieces. And current matrix arrays, they have thousands of these pieces. We call it elements. And these 1,000 elements, and this is the specificity of ultra-fast imaging, is that they need to be connected to a channel. So what's the channel? So it can be seen as an oscilloscope, this device to be able to measure an electric signal. So we can imagine that these matrix probes, they need to be connected to 1,000 oscilloscopes. So an oscilloscope, you see, it's the size of a computer. So imagine 1,000 of them. It makes a big machine. So this is the current state of the art. And this big technology is only to make an image of 1 centimeter per 1 centimeter. So if you want to extend this to a human organ, which is 10 centimeters to 10 centimeters for the least, then you're going to need to multiply this device by 100 or 1,000. Imagine 100,000 oscilloscopes stuck together. It's going to be bigger than an MRI and even more expensive. So this is for now impossible, and no one has been crazy to do it. So we that was the starting point. This is not doable. We need to find a way to reduce this number of channels, to reduce the number of stacked oscilloscopes. So how can you do it? Okay, so you need less elements in your matrix, but if you do that, then you have less energy. So we said, okay, we want less elements, but we want them big to cover a big surface of probe. But if you do only that, because your elements are big, they are not able to work together. They're going to stay alone, and a matrix probe, they need to work as a team. And like every work in life, you need to work as a team. No, nothing can be done alone. It's the same for a probe. And so they need to see each other. If they are big, they cannot see each other. They can see only in front of them. So the trick here, and it's really the key invention here, is to put an individual lens for these big elements to be able to see each other, to see on the side. And doing that, they can work together. They can make an image. They recover their nature of being able to work together and make a beautiful image. So can be compared to an optical lens, something that you put on your eye to see again. We do that exactly the same for the elements of the matrix probe. We put an acoustic lens for them to see again and to be able to work together. And like this, we want on every side. The size of our probe is huge, 10 centimeters per 10 centimeters. No one has ever been able to do that, such a big ultrasound probe. The number of elements is low, about 200. We are talking about 100,000 earlier, and it's only 200 in this probe. And they have this acoustic lens that can restore the good imaging quality. And I could apply it to ULM to see all the vessels that we talked earlier.
You're listening to The Convergence on ReachMD. I'm Dr. Brian McDonough, and my guest is Dr. Clément Papadacci. And we're talking about 4D ultrasound, the technology, and practical uses. I want to move to some clinical uses to help me visualize this. And for those who've been listening to this, you're a physician at a bedside. You're with the probe. What is my workflow? How long would a scan take? And what will I be seeing on the screen?
Sure. So that's a good question, and we still are working on that for sure. But I have a very good sense of how it works. As you may know, we are moving on clinical trial very soon. So we have already done some human volunteers, and we are very, very near clinic. So we have a very good sense of how it works now. So as any echographic system, you need some gels. You need to put some gels on top of the probe to create to be able to the ultrasound to be able to pass. So this is no different. Maybe the difference because the probe is so big, you're gonna need a big amount of gels. Okay, so maybe something that you need. When I go to the hospital, it's always funny because the tube of echographic gels are always empty. So you're running in every room to try to find the one that's full. So maybe you need to take that into account and get one near you. And then you position it on the patient. And then on the screen, you have a beam mode image, which is a real-time image of what's going on inside. But of course, you won't see the beautiful image as you will see in the video, and because this takes time and post-processing. So you won't see that in real time. This real time will only tells you, okay, you're in front of the organ of interest. You're good to go. So when you're good to go, you start injecting some microbubbles. So in regulations, you're able to inject one dose, which is 5 milliliters. So my advice would be, don't inject everything in the same time. inject little by little. So you can do boluses of 1 milliliters every 1 minute. So, and then you start the acquisition. So basically the acquisition will start 5 minutes, and every minute you inject a bolus of microbubbles of 1 milliliter of microbubbles. And then everything is stored on the machine, and the data. So we have also tools to see if the data are correct, and the positioning is definitely good. So you have pre-processing tool to not be completely blind, and then you do the post-processing offline for now, and you get the beautiful image in like 10 minutes, 15 minutes. You can already see some of the results.
You mentioned that you're heading into human clinical trials. What are the first clinical applications that you're targeting at this time?
So we are targeting an application for atherosclerosis patient. So the patient that have plaques all around their body, to see how it impacted the vasculature. And we are targeting two organs, the heart, to see if we can already detect some blockage in the coronaries. And we're also targeting the brain, and we want to see the circle of Willis and how it could affect the distribution of the blood. Because these patients, so they have big plaques in the carotid, and they will undergo surgery. And the physicians, they want to know how the circle of Willis will be able to redistribute the blood during the surgery, because it's a very heavy surgery. You need to clamp the carotid, so you stop the blood. And so if the circle of Willis, as you may know, it redistributes the blood through the collateral arteries. But if it's incomplete, then there is a risk of a stroke in the patient. So they have tools for sure, and they have tools that they use MR angiography, CT angiography to look at the circle of Willis. But sometimes there is some shadowing. You're not sure if the communicating arteries is really functional. And we are very confident that with this technology that we developed, we will be able to quantify the communicating arteries, the way they work. We have a very, very nice work that's finished, and that we're going to be published very soon on primates, where we could very finely characterize the circle of Willis and its ability to redistribute the blood inside our main cerebral arteries. So that's basically the application that we are targeting. So you see, it's a complex clinical trial, because we're going to try on the heart, on the brain, on the same patients, and we think we can make a difference in the decision afterwards for surgery.
Well, in cardiology, for instance, patients can have angina and they'll have normal coronary angiograms. So the imaging we have can be a source of frustration for the cardiologist trying to figure things out. What would your probe show that might change management as you begin the testing and you're seeing what's happening?
Yeah, this is really an interesting application. So you reference to this big family of pathology, coronary microcirculation dysfunction, the CMD. So the decision tree is very, very complex in this pathology. Anyone that's listening to us that's been confronted to this kind of patient, as an angina and a normal coronarogram, then they pass so many tests before concluding that that must be a CMD. Being able to visualize microcirculation right away could save many times for this patient, and also diagnosing very early is important for sure, but also to develop a new therapeutic strategies, because it's very difficult for companies to develop therapeutic strategies when they can't see the effect directly on what they are targeting. So I think it's both to diagnose, but also on the follow-up, on the therapeutic follow-up. That's very interesting. As you know, ultrasound is not ionizing, so you can use as many times that you want. So I think it could make a big difference in this kind of pathology. Yeah.
Another thing that I'm thinking of, we talked about it before, how metabolic syndrome can lead to liver fibrosis through fatty liver changes. One of the other things we're seeing, obviously, is an increase in the number of people with type 2 diabetes and people who might in time develop diabetic nephropathy. Your tool, again, could really help looking at the entire kidney microcirculation in a 4D approach. I mean, with so many people battling this, it would seem like the uses are almost endless for perfusion defects and responses to treatment, those sorts of things.
Yeah, exactly. The same as for CMDs in this pathology that's difficult to diagnose. It's difficult also to make groups. We have so many pathology that we put all the patients in the same groups because they just don't respond to other markers and easy, let's say, well-known biomarkers. So by creating new biomarkers like microcirculation function, um, it could really help clinicians to say, okay, so this pathology, it can be divided in 2 and 3. And in this first group, we can give this kind of medication. And in this second group, another kind. And I can follow up what's going on in the microcirculation part. I think this gives a lot of hope in these pathologies that the decision tree again is very complex, and it's often called this disease the diagnosis by exclusion. You exclude every other causes, and afterwards, when you have excluded everything, you say, okay, it must be that. And I'm sure that seeing the microcirculation, visualizing it, quantifying it, and quantifying the function, and comparing to what's normal and what's expected will save a lot of time for clinicians and for patients for sure that are suffering for that.
This is portable. I was thinking about my experience with point of care ultrasound and how we're using it now in offices, ED, ICU. And where I saw the challenges was getting the results into the electronic medical record so that people could use it and see it. But that was a very simple problem to have, although very difficult to deal with. This is portable. And you mentioned connecting to small equipment. So how do you see point of care applications working? And could we use this technology in places such as the ED or ICU or even in one of our outpatient clinics?
Yeah, that would be really the dream, to make it easily transposable to anyone that want to see more about know more about microcirculation. And as you mentioned, because it can be connected to any ultrasound device, it will be in the clinic or whether from a small company that we may start, or a big company that wants to integrate the technology to their ultrasound system. So I'm really hoping that it gets to the hand of any a practitioner that feels that has a use. And I think another part of your question is how easy the biomarker will be interpretable. Will it be easy for anyone to read the images? And I think this is the work that we are doing now. It's making the ultrasound images visualizable, but also working with clinicians that tells us what they want to see. Because sometimes you make a big 4D images, but the clinician in his specialty only wants to see one part of it. And you can only select what you want to see if first of all, you have seen all. And this is my big trust in 3D and 4D imaging is to get simple, you first need to get complicated, because you don't know what you want to see. So seeing it all makes you then select the part that you want to see and the biomarkers that you want to see. And maybe for some application and some clinicians, they will want to see just one value or just one piece of the image, and it's fine. And this is what we want. We need to work with a physician now for them to tell us what are important in their world, in their application for the patients.
You alluded to the use of micro bubbles. Certainly, that contrast agent use is kind of something that was necessary for the probe. What can't your probe do yet? What are some of the limitations physicians should understand about this?
Yeah, I think it's for now, we have developed it really for the application of ultrasound localization microscopy. So we can't expect for now to have, for instance, beautiful B-mode images, so real-time B-mode images in 3D, like you would see the baby in the belly of his mom. This is not doable for now because the probe has not been done for that. And I think other device does it very well. And the sonographer and the clinician, I think they are fine with switching probes for different applications. So I don't see that to be an issue. But of course, because we want it all, we will try to improve on that point.
One of my favorite parts of the Convergence program is talking about the future because, it's already exciting. And then you start to think of where we go next. What is the timeline moving forward? Like here in the United States, when will physicians actually be able to order a study, use the probe from a realistic standpoint?
Yeah, I think that's what's also fascinating with this project is that it goes very fast. 3 years ago, I had the idea of this lens, and we were doing a simulation. And I remember the first time I sent the publication to my peers to be peer reviewed, because this is how research worked. The researcher did not believe it could work because we were only doing simulation, and they were saying, no, it won't work because this kind of probe, they do bad imaging and this just can't work. And it was very, very difficult to get published, the first paper 3 years ago. So it was published in 2022, actually. So you see, the 3 years ago, the past that we've done is really fascinating to see how fast we went from this little idea, this little simulation made with the team, but you just need a computer. And 3 years ago, you move on whole organ animals. We already did porcine models. It's published. Primates, it's about to be published. And we are moving next year to clinical trials. So I think that's the magic of this project. It's moving very fast. And after that, we want to do other clinical trials on different organs. We are thinking now of maybe launching a company, like I was telling you, but we're also very open to also work with big companies. So we really think this device and this technology should spread as fast as we can, because it can make a difference. And we still there are still many things to discover, and physicians, they are the right tool for that, because they have many ideas, they are very creative, they have the patience, they know what they want, and so some of them, they really want to do research. So yeah, that's the next step, and I think it will go fast. It will go fast.
With your background in cinema, the great producers, directors, writers all have to have tremendous imaginations and vision going forward. If you could wave a magic wand, and I'm sure you've thought about this, having this technology everywhere, let's say a 10-year period, what do you think would change in how we practice medicine if this tool, like, really, it's on its way, becomes a tool that we start using?
Yeah, so it's a nice question. I've always been fascinated because I'm from ultrasound. I see the X-ray that's been performed every day in the clinics, when you see the technicians that comes and takes your hand and look at the broken hand and see the bones, and the images goes to the radiologist that analyze it, and it's done. It's so easy that the technicians can perform the act, and then the specialist, the physician, analyze the image, and the diagnosis is, it goes with the current flow. It's easy. It's fast. And I think that this probe could be like that, because you don't need a big specialist to position the probe, because you can make a big probe that you're sure will cover the organ, and then you make this image of the entire volume, and get to the radiologist, or to the specialist of the domain, and he can interpret it and give you the diagnosis fast. Um, you know, I think I'm dreaming as a physicist, and working on the medical field, to some way make a difference in the world of the clinics, and that some patients get a bit of what I do, and I think this is my biggest dream, is to be able to make a difference for patients.
That's a wonderful, wonderful dream. And, self-serving, this technology grew out of work in Paris and your research. For physicians watching, listening all over the country, how do you stay connected to emerging technologies that could transform our practices? Do you have any advice where people should look or read? I mean, these things just don't pop into the journals all the time. Any way you suggest we could get more engaged or learn if we're interested?
I think the key is to stay really open-minded, and try to find the researchers around that has this kind of technologies, and want to apply it in the medical field. Actually, we are very, very interested about physicians' output, and I get fed from that. I'm a physicist, but I learned to talk with physicians, because it's a key. It's really key for us to be able to understand each other, and to interact. Sometimes we have a new tool, and we go to see a physician, and we tell them, "Oh, how can it serve you?" And sometimes it's the other way around. Physicians, they come and they say, "Oh, I really want to see this part. I really want to quantify this part. Do you have a tool for me?" And we cannot grow if we don't have this exchange. And finding a physician that we can talk with is a great value. So let's say my advice would be, stay open-minded. Um, Everything doesn't work like the first time. Sometimes you have some development to do together. So don't expect that you press a button and it works. Sometimes it's like that when we work together. But it's a great adventure, and I recommend it to any physicians that are listening to us today.
Dr. Papadacci, what would be one message you want every physician listening to remember about ultrasound's potential?
I think a big revolution is coming in ultrasound, and the new tools is going to help their life, I hope, and the life of their patients.
Well, it was our honor to have you. Dr. Clement Papadacci, I want to thank you very much, very, very much for taking the time to join us.
I would like to thank the team that it was very a great job that everyone performed. I would just want to quote my student Nabil Etour. That's a really good part of the project. And I would like also to thank the physicians that are listening to us, because like I mentioned earlier, they are really the input that enable us to do all this beautiful work.
You've been listening to The Convergence on ReachMD, where innovators and physicians explore the technology transforming medicine. To hear about other technological advances shaping the future of healthcare, visit The Convergence on ReachMD.com, where you can be part of the knowledge. Thanks for listening, and we'll see you next time.